Thank you to everyone for being here today. I've been tasked with discussing the angiosome concept and specifically whether there's feasibility and efficacy of a direct revascularization versus an indirect revascularization approach for critical limb ischemia. These are my disclosures. So the angiosome concept, Mahmoud touched upon this, is not new. This has been around for over 25 years now. It was originally described by plastic surgeon Dr. Taylor, who described in the lower extremity blocks of tissues, essentially three-dimensional blocks of tissues, which include a source artery, but the overlying skin, the subcutaneous fascia, muscle, and bone. And the concept is that if you want to achieve wound healing, you actually need to achieve direct revascularization of the specific angiosome, this block of tissue where the wound is in fact located, and that's the greatest likelihood of achieving limb salvage and certainly wound healing. 6 distinct angiosomes have been described. I'm not going to belabor the point, but obviously they are fed from the 3 infrapopliteal arteries, the posterior tibial, anterior tibial, and even branches of the perineal artery. And the idea is, depending on where on the patient's foot you have a wound, you would want to ideally choose that vessel to be your revascularization target, whether it's with open surgical bypass or endovascular therapy. And so, again, you should want to directly perfuse the tissue supplying that area over another area in the foot, a so-called indirect revascularization. And so for heel wounds, you would ideally want to revascularize the posterior tibial artery. For the plantar foot, again, the lateral plantar vessel to be specific, the lateral ankle, the perineal artery, and then the dorsal part of the foot, the anterior tibial artery. And this is all sort of intuitive if you believe Dr. Taylor's theory. So there have been numerous retrospective studies and a few retrospective studies. I'm not going to exhaustively review the literature, but this is a great retrospective review from Rich Neville, whose entire practice is largely focused on limb salvage down in Washington, D.C. And he looked at patients where a direct, again, specifically located at the target where the tissue loss was versus an indirect revascularization was performed in his own practice. And he clearly found more complete healing in those patients that underwent direct revascularization. Here's another example of publication in Journal of Vascular Surgery from Osamu Ida in Japan, another physician who's dedicated his entire practice to the treatment of critical limb ischemia, where he compared 118 patients with direct revascularization versus 85 with indirect revascularization. And again, you can see the limb salvage rates are significantly divergent, favoring direct revascularization. Lastly, a patient from earlier this decade by Alexandrescu from Europe, who again looked at 2 different groups. Those that were treated somewhat randomly without an angiosome-directed approach, where at 3 years there was 79% freedom from major amputation, whereas group 2, where they did adopt an angiosome-directed approach, they were able to achieve 89% limb salvage at 36 months. So proof of concept may in fact be there. I think this is a ripe opportunity for prospective research, perhaps even public funding. I'm just going to give you a couple of brief clinical examples. This is a 63-year-old male with diabetes, end-stage renal disease, clearly at high risk for a limb loss. And again, you have this largely left heel ulcer. The angiogram, the inflow was completely unremarkable. You have this focal stenosis in the mid-superficial femoral artery. There's single vessel runoff to the anterior tibial artery, which have a couple of focal stenoses, but there's really nothing going to the hind foot. So the question is, do you go after the anterior tibial artery, or do you go after, for example, something else? And is there even an option to open up the posterior tibial artery and give direct circulation to the heel, or is that fruitless? And should you try a different approach? So obviously the inflow here is the superficial femoral artery, which was successfully treated with balloon angioplasty and eventually drug-coated balloon angioplasty. And numerous attempts were actually made to get into the posterior tibial artery to try and make do of it, but this was largely unsuccessful. And after this, we said, well, if we can't get the direct, specifically posterior tibial artery revascularization, maybe we should choose a semi-indirect approach. And we decided to use a CTO device. This is a CTO device being focused on the perineal artery. And this was able to be successfully wired, and obviously balloon angioplasty. And now you have direct flow to the posterior division, the posterior communicator of the perineal artery, giving perfusion to the heel. And again, not ideal, but certainly better than just opening up the anterior tibial artery. And this actually patient did successfully achieve a wound healing. It took several months, as these cases typically do. But again, I think supporting the proof of concept that perhaps direct is better than indirect. Here's another example in the last few moments I have left, a great toe ulcer. SFA is remotely diseased, but not significantly. Single vessel runoff through a reconstituted perineal. The distal anterior tibial artery and dorsalis pedis artery reconstitute. And obviously the question is, which do you revascularize here? And if you want to go for the dorsal foot and the toe ulcer, you would choose the anterior tibial artery. And so we doubled over a hydrophilic guide wire here, drilled all the way down into the anterior tibial artery, got a guide wire through, did balloon angioplasty, ended up having a couple of flow-limiting dissections, placed scaffolds here in the proximal anterior tibial artery, but got a very, very nice result after the scaffolds were placed with a palpable dorsalis pedis pulse. So there are limitations. The anatomy can be variable, as Mahmoud mentioned. You need to be significantly concerned about compromise to collaterals in end-stage renal disease and diabetes. There isn't prospective, robust data to prove this concept, but again, it is intuitive. So to summarize, the concept is generally accepted, it's widely practiced, and there's retrospective literature on this. There's no difference, it's important to note, in reintervention rates and mortality, but in general, limb salvage and wound healing appear to be better in retrospective series when direct revascularization is performed as compared to indirect. Thank you for your attention.